Hello, welcome. We are discussing gastrointestinal tract, the gastrointestinal system in the pharmacology modules. And if you look at the slide, we're going to discuss two different kind of entities. The first one is called IBS and the second one is called IBD. What's IBD and what's IBS? IBS is irritable bowel syndrome, and irritable bowel syndrome could be of three different varieties. Irritable bowel syndrome with predominant diarrhea, irritable bowel syndrome with predominant constipation, or the irritable bowel syndrome with predominant abdominal pain. Coming to the second one is IBD. That's not irritable, it's inflammatory. Inflammatory bowel disorder or inflammatory bowel disease. In this we have two types of illnesses. One is called ulcerative colitis. Remember the word colitis, it straightway will indicate that there is affection predominantly of the colon, that's the large intestine. The second disease under this category, IBD, is Crohn disease. And when you say Crohn disease, there's involvement of part of small intestine as well as the large intestine. So ulcerative colitis means large intestine, that's colon, and Crohn disease means small and large intestine. Let's start with the irritable bowel syndrome or IBS. IBS is an idiopathic entity and the disease is chronic and it's relapsing. It's idiopathic, we don't know the exact cause of IBS. What happens in IBS? In IBS there are two things. Number one is abdominal discomfort. What kind of discomfort? There can be pain, sensation of bloating, distension, and abdominal cramps. So that's abdominal discomfort. In addition to this, the patient has altered bowel habits. So the altered bowel habits could be, there may be diarrhea which is predominant, or there can be constipation which is predominant, or few patients alternately suffer from both diarrhea as well as constipation. So abdominal discomfort plus altered bowel habits, it indicates irritable bowel syndrome. What is going to be the purpose of treatment? The first purpose of treatment will be to try to relieve the abdominal pain and the discomfort with which the patient is suffering, and the second one is to try to improve the bowel function. So let's see how we can address these two issues to relieve the abdominal pain, discomfort, and the second was to produce improvement in the bowel function. We first start discussing IBS with predominant diarrhea. So this patient's major complaint as far as altered bowel habits is increased GI motility. And because there's increased GI motility, we think of using antidiarrheal agents. What are the antidiarrheal agents which we could look for? Number one, if you remember the previous sessions, loperamide, which is a better antidiarrheal agent as compared to the second agent, that's diphenokylate. So loperamide and diphenokylate in the top order. Then you have M3 blockers, that's dicyclomine and hyoscyamine. These can work as antidiarrheal agents. These are anti-muscarinic drugs or anticholinergic drugs. Next you have a 5-HT3 antagonist in the form of alocetrone. This is useful in IBS with predominant diarrhea. And the next newer agent is a peripheral potassium antagonist, that's called fedoxotine, a peripheral potassium antagonist. And you have a drug which is rarely used. It's a reserpine analog and it lacks anticholinergic adverse effects and it decreases the hypermotility. Name of the drug is mebeverine. So have a look at it once again. The antidiarrheal agents, loperamide and diphenokylate, then the anti-muscarinic agents, one 5-HT3 antagonist alocetrone, peripheral potassium blocker, fedoxotine, and a reserpine analog in the form of mebeverine. We go to the next slide. For IBS with predominant diarrhea, we also use some miscellaneous group of agents after the antidiarrheals. These miscellaneous agents which could be helpful, number one is clonidine, which is an alpha-2 agonist. The next one is buspirone. What is buspirone? It's an anti-anxiety agent. It's a 5-HT1A partial agonist which is used as anti-anxiety agent. Number 3, a cholecystokinin 1 receptor antagonist, a new drug called loxiglutamide. CCK is cholecystokinin 1 receptor antagonist, loxiglutamide. And lastly, you have a drug that's sumatriptan, which is used in the management of motion sickness. 5-HT1B and 5-HT1D antagonist. I'm sorry I said motion sickness, I meant to say migraine. Sumatriptan, which is used in cases of migraine. 5-HT1B, 1D antagonist. So in the miscellaneous drugs, we have clonidine, alpha-2 agonist, buspirone, anti-anxiety agent, loxiglutamide, a CCK1 antagonist, and an anti-migraine agent, sumatriptan. So that's about IBS with predominant diarrhea. Now we find out what's used for IBS, irritable bowel syndrome, with predominant constipation. Now because there's predominant constipation, we try to treat symptomatically this symptom of constipation by using various drugs which could lead to increase in the motility. So first, the simplest way to treat is the fiber supplements. Try to increase the fiber content of the food and try to give the fiber supplements. They are going to soften the stools and they are going to reduce the straining at stools. Increased gas production by the fiber supplements, however, can lead to some symptoms of bloating and discomfort. The second group of drugs we can try is osmotic laxatives. They'll also soften the stools and they'll improve the frequency. And the drugs which could be used is milk of magnesia, that's magnesium hydroxide. The third agent useful in predominant constipation IBS is a 5-HT4 partial agonist, that's tegaserode. Tegaserode increases the motility of the colon and it increases the chloride content in the colonic lumen, leading to increased water secretion. Tegaserode has shown large incidence of myocardial infarction and strokes, and this is why in many countries tegaserode has been withdrawn. The next drug which is useful for IBS with predominant constipation is a chloride channel activator, and that's called lubiprostone. It increases the chloride secretion, increases the water content in the colon, and it stimulates the motility. So these are some of the drugs which we had already discussed when we discussed the management of constipation, but they are coming here because it's irritable bowel syndrome with predominant constipation. Next we move on to irritable bowel syndrome with chronic abdominal pain. That's the third variety. Predominant diarrhea, predominant constipation, and IBS with chronic abdominal pain. This chronic abdominal pain type of irritable bowel syndrome responds well to tricyclic antidepressant drugs. Only difference is we use TCAs or tricyclic antidepressant drugs in a low dose. Look at the dose, just 10 to 50 milligrams every day, amitriptyline or desipramine. These drugs can be tried in this patient, and there are various mechanisms proposed how low dose TCAs are helpful in IBS with chronic abdominal pain. The first mechanism is TCAs probably alter the central processing of the visceral afferent information. So alteration of the processing of the information which is coming from the visceral afferents. That's the first probable mechanism. The next mechanism is got anticholinergic effect, and this anticholinergic effect is going to produce decreased motility, and this decreased motility is going to help relieve the abdominal pain. The third mechanism, it's got 5-HT effects, the enteric 5-HT effects, that's the 5-HT effects in the intestine, and this also results in decreased motility. There is no effect on mood when these drugs are given in low doses, so we don't have to worry about the interference with the mood and interference with the emotion. So low dose TCAs try to work by altering the central processing of the afferent information, by anticholinergic effect, and by enteric 5-hydroxytryptaminergic effects. So that's about irritable bowel syndrome with chronic abdominal pain. Now we move on to discuss the second type of entity, what we call it as inflammatory bowel disease, IBD, inflammatory bowel disease. And as we said in the beginning, there's ulcerative colitis, that's the affection of the colon. In ulcerative colitis, the inflammatory process is usually superficial and it may extend proximally to a variable length, but predominantly is the involvement of the colon. Whereas in Crohn disease, small and large intestine both are involved in the pathology. And Crohn disease can get complicated by formation of strictures, fistula or abscesses. So that's the difference between ulcerative colitis and Crohn disease. Let's first sort out what are the drugs useful for ulcerative colitis. In ulcerative colitis, there are two issues involved. Number one, disturbances in the immune system. And number two, the imbalance between the pro-inflammatory and anti-inflammatory cytokines is one. And second one is the immune system involvement. Which are the drugs which could be used for ulcerative colitis? Number one are called aminosalicylates. The second group of agents useful are called glucocorticoids. And the third one are immune modulators. I hope you can look at these drugs and realize salicylates are going to be anti-inflammatory agents. Glucocorticoids are going to affect the inflammatory process as well as it has got the immune modulating effect, and the immune modulators themselves because there is affection of the immune system. First we discuss the aminosalicylates. What is an aminosalicylate? It's a combination of 5-aminosalicylic acid with another moiety. This drug aminosalicylate reaches the colon, the bacteria split it, and what is released is 5-aminosalicylic acid. 5-ASA is also called mesalamine. So you have a combination of 5-aminosalicylic acid with some other substance, and when it's taken orally, it reaches the colon, the bacteria split it, and it releases 5-aminosalicylic acid or 5-ASA. This is a salicylic acid derivative, so it's going to inhibit the cyclooxygenase, that's COX, and going to lead to decrease in the PG synthesis, and this is how it's going to produce a local anti-inflammatory effect in the colon. The second mechanism is it's able to inhibit the cytokines and is able to inhibit the nuclear factor Kb, that's the transcription factor for pro-inflammatory cytokines. So when this factor is decreased, the pro-inflammatory effect of the cytokines is going to be inhibited. So two methods. Number one, inhibition of PG synthesis to produce local anti-inflammatory effect. And second, inhibiting the cytokine function and inhibiting the nuclear factor Kb. The third mechanism is aminosalicylic acid inhibits the formation of the superoxide free radicals. So by these three mechanisms, aminosalicylic acid will work in ulcerative colitis. Let's have a look at this table. What are the compounds which are used? The first column is showing you sulfasalazine, then balsalazine and olsalazine. And I've written here olsalazine is the better tolerated agent out of these three agents. What is shown in the second and third column is this sulfasalazine is going to reach the colon and is going to get broken down into two substances. Same way for balsalazine and olsalazine. So what I am going to show in the second and third column is what are these two moieties which are released in the colon. Sulfasalazine gets broken down into 5-ASA plus sulfapyridine. Balsalazine gets broken down into 5-ASA plus 4-aminobenzyl beta-alanine. And the last substance, olsalazine, gets broken down into two moieties, and both the moieties are 5-aminosalicylic acid. Second one is also 5-aminosalicylic acid. So this is how these substances get broken down, and we get 5-aminosalicylic acid in the colon. Aminosalicylates, they are known to induce remissions in patients with ulcerative colitis, and they are helpful. They are also available as suppositories or enemas, which will be used only if the disease is restricted to the rectum or the disease is restricted to the distal colon. If the disease extends to proximal colon, then we need to give the treatment by oral route of administration, as we are discussing it right now. Aminosalicylates can lead to certain adverse effects. Number one is there is a sulfur molecule involved, and this is why there can be anorexia, nausea, vomiting, and headache. This ANVH is anorexia, nausea, vomiting and headache. Then allergic reactions and depletion of folate. So due to the sulfur molecule, you get mainly the hypersensitivity reactions, GI intolerance and depletion of folate. Prolonged use of aminosalicylates in males is known to produce oligospermia and male infertility, which could be reversible. Oligospermia and male infertility. So these are the adverse effects of the aminosalicylates. The second group of drugs which we can think of using is glucocorticoids in the form of prednisone and prednisolone, and they are the mainstay of treatment of ulcerative colitis, especially in the acute situations and when there is an exacerbation of ulcerative colitis. These drugs are immune suppressants, plus they produce anti-inflammatory effect, and the drugs which we use is prednisone and prednisolone, and you give at least 2 weeks to expect the inflammatory response, and then gradually taper the dose and continue it for next 6 to 8 weeks. And then you can start a 5-aminosalicylic acid for maintenance. So that's the way to use prednisone and prednisolone. Wait for 2 weeks for anti-inflammatory response, and when you see an improvement, you can decrease the dose and taper it over a period of next 6 to 8 weeks, and then start a 5-ASA for your patient for maintenance. Next we discuss the immunosuppressive agents which are useful in ulcerative colitis. Have a look at the slide. There's azathioprine, there's 6-mercaptopurine used as maintenance. And these drugs, these are anti-cancer agents, and they can lead to vomiting, nausea, bone marrow suppression, hepatotoxicity, and a commonly known adverse effect with these two agents is pancreatitis. So that's about the immunosuppressant drugs. Next, we go to discuss what is Crohn disease and what is the common principles of management of Crohn disease. So in the IBDs, that's inflammatory bowel disease, the second disease is Crohn disease, and as we already said, it affects the small intestine as well as the large intestine. The treatment is similar to ulcerative colitis because it is inflammatory bowel disease. Let's have a look at the slide. The treatment similar to ulcerative colitis means you use aminosalicylates, use glucocorticoids, and you can use the immunosuppressive treatment. That's the first part. The second part is plus what you need to add is antibiotics, and you also need to add the biological response modifiers, BRMs. So ulcerative colitis is aminosalicylate, glucocorticoids and immunosuppressive treatment. Crohn disease, all this plus antibiotic and a biological response modifier. Antibiotics which are useful in Crohn disease are metronidazole and or ciprofloxacin. Antibiotics are useful for short time and if there is infective element, if there is abscess or fistula formation. Then you give BRMs, that's biological response modifiers, and these are all monoclonal antibodies to TNF alpha, that's the tumor necrosis factor alpha. And there are many monoclonal antibodies now available. Let's have a look at them one by one. First one is infliximab, is a mouse human chimeric TNF alpha antibody, and it's known to produce remission in 40% cases. The second one is adalimumab. This is a full human monoclonal TNF alpha antibody, has got a longer half-life and is comparatively safer, it's got less adverse effects. So infliximab and adalimumab. Next we have certolizumab. It's a new agent. It's a pegylated fragment of TNF alpha antibody. So you have three antibodies, infliximab, adalimumab and certolizumab. Lastly, you have methotrexate, which controls the relapse and is also useful in resistant cases. So if there's a severe relapse, you can think of using methotrexate as a biological response modifier, and you can also use methotrexate in the resistant cases of Crohn disease. With this, we come to the end of the discussion of the IBS, that's irritable bowel syndrome, and IBD, that's inflammatory bowel disease. Inflammatory bowel disease, we discuss ulcerative colitis and Crohn disease. I am sure this particular module on GIT is going to be useful to you. Take care. All the best.